This is a big, big agenda that you all have collectively set before us. Obviously, the Jason report came out recently, I mentioned that earlier, and recommended that we have got to take some very important steps to start to push this process along. Otherwise, we will have the situation that Sachin described, which is we'll have a whole lot of achievement, but not much effect and not much realization for the triple aim. So start by telling us what's foremost on the agenda now of ONC as it thinks about moving this forward.
Oh my. So I think the Jason report's a good lead-in, and if you haven't exposed yourself to it, Google Jason, Jason.
And it's right on healthit.gov.
It's on our website, and actually our national coordinator, Ken DeSalvo, blogged about it last week. And Jason doesn't mean anything. It doesn't stand for anything, so don't try and decrypt the acronym.
It's just a group of smart people who get hired by the government periodically to weigh in on important technology and science issues.
They call themselves the Jasons. So they talked about some things that we are thinking about. So as we shift our focus from meaningful use, capital M, capital U, to meaningful use, lowercase m, lowercase u. And the reason that we make that distinction is not that the Meaningful Use Incentive Program, which is CMS's program, is going away. It's not going away, but it's reaching a steady state, right? This isn't a new achievement anymore. It's optimization. And as John will tell you about implementing health IT in a care delivery organization, and we've learned both locally and nationally, you're not done when you plug the thing in. You have to shift to sustainability mode, and you have to shift away from sort of the bells and whistles of implementation to how do we optimize, and how do we make sure we're using these systems as well as they can, and how do we think of the converging vectors of our policy ambitions. And so what are some of the things that I'll try and answer Susan's question and not be DC about this. What are our priorities? So interoperability, I think, was mentioned. You mentioned as we started, and the Jason report certainly encouraged us to focus on interoperability. I would argue that interoperability is a method. It's how we're going to get to what we need to get to, and what we're going to get to is better care. And all of the components of the triple aim that you mentioned earlier. We do need to do it right, and as John even mentioned, doing it right means accepting what folks send, but also, as I described in my talk, being very explicit about what we're expecting of what gets sent. And so we are thinking long and hard about being very focused about, as we move information, being more explicit about exactly how one needs to express the information that is moved. Another piece, again, invoking the Jason report, that we're thinking about is how does one get out of a product that they have? How do we get information out of a product? How do we replace the functionality of a product that we want to replace? And as we look at the way that, as John described, the social media activity that's happened, all of these products have components called APIs, and the non-geeks in the room, API stands for Application Programming Interface. It's really how one gets data out of a system, and in fact, one of my favorite APIs is Twitter's API. It's very simple, and of course, for business reasons, and remind me to complain about some of the business concerns that I have about some of the factors that are at play here in our industry. But for business reasons, Twitter actually turned off some pieces of their API. But it's really a way to get information out of a system. So let's say Health IT is a set of products that folks have had to purchase over time. But now, let's say a functionality, somebody comes out with a better mousetrap, a better way to prescribe medications, a better way to invoke clinical decision support, a better way to do quality measurement. Today, we're locked into the 5 or 10-year contract that we have with the company that sold us a product, which doesn't foster innovation. So some have called on us to think about how we would express requirements for vendors to create APIs so that all flowers can bloom on top of the current architecture. So I think I've probably said enough for now. We should probably move on to John and Sasha.
Well, and to that point, you have now people like Len Steele, the CEO of Geisinger, going around saying, please liberate me from, I won't repeat the name of the company whose EHR he wants to be liberated from, but it's precisely to this point. It's that we are imprisoned in a way in these proprietary systems for the moment, and if not the government, who is going to challenge us to open it all up?
And some would argue that the government shouldn't do it, and I think this is the paradox of what's government's role here. Everybody's car has a little plug-in thing that you can actually connect through Bluetooth to your smartphone. All modern cars have that. It's not necessarily required by the government that that happen. But that third brake light in the back of your car is required by the government for safety reasons. So where is it that the government says you must do this, and where is it that the government allows the market to do what it needs to do and allow for innovation to occur? That is our challenge.
So John is a frenemy of the government out there in the system,
Wow.
working every day. How do you see it?
Well, I mean, come on, Jacob and I are the closest friends, you know. I have this tension, actually, when I meet with Karen DeSalvo, and I say, on the one hand, you're doing God's work. But on the other hand, I am the guy who actually implements these regulations that you foist upon me, and the fact that
you have to shovel the manure in your day job as well.
You know, the fact that I have to spend 12 hours calculating numerators and denominators in a certification process would be something I would much rather not do. I'd like less prescriptive certification. Where can the government help? Well, the government is a convener, government is a platform. If we look at where the state government of Massachusetts has taken the Commonwealth, the state decided it would be a good service to create centrally, with patient consent, a list of the relationships you have with caregivers. So as you look at the Jason report, what it suggests is that we move to different kinds of interoperability and different models. Well, if I want to do that, let's imagine, Susan, you come to the emergency department and you have records scattered at 5 caregivers, specialists, primary caregivers, clinics, etc. I don't even know where to look for your data, but if the government or some commercial entity, with your consent, creates that relationship list, suddenly it is an enabler for products. Now, it doesn't necessarily force you to create product A or product B, but it is an enabler for a suite of products. So our Commonwealth has such a thing. This relationship locator service is just beginning to enroll patients because it's opt-in consent. Basically, you decide what relationships you want to disclose or not. And so what have we done with it? Well, in the emergency department, we can say, oh, there are 5 places you've been where you've disclosed information to be released. Click, 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 and here is the information. This is interoperability, delivering safe, quality, efficient care to you based on information you've chosen to disclose. But you could imagine all kinds of purposes for this kind of service where the government created standards and created policies and then told the marketplace, go innovate. Quality warehouses, clinical trials, enrollment possibilities, etc., all driven, of course, with patient consent. And so, same answer you gave, which is I would rather not see the government tell us we all must have Google Glass. I would rather the government tell us, here's a set of standards, here's a set of policies, and here's some enablers that the market may not create on its own. Once that foundation is laid, go innovate.
Set the railroad gauges equally and let
and whether you want to drive a Prius, a Tesla, or a Ford, that's totally up to you.
Just don't drive it on the railroad tracks.
Yeah, that's right.
Sachin.
So, I take a little bit of a longer view of this whole issue, and I think, if you look at any industry and you look at the transition from kind of paper to electronic or sort of analog to digital, there's always this kind of period of, holy cow, this is a disaster. And then 10, 15 years later, almost kind of without warning or without kind of notice, things just start to work better. And the analogy is sort of online banking. If you kind of look at kind of the early history there, and you look at Quicken, and you look at sort of what Quicken did for people in 1988, Quicken was there's a receipt in front of you, and then there's a screen, and you're sort of entering onto the screen what's on the receipt, and voila, what matches the screen and the receipt actually match each other. And that was the core functionality of Quicken in the late 1980s. And you sort of look at that and you say, why would anyone use this software? Because it was really just, frankly, it was just data recording like current EMRs are. And then, you fast forward 5 years, and you have some early adopters with online banking in 10 years and 15 years. And before you know it, none of us have checkbooks anymore. None of us have bank statements anymore. And you have these fully functional systems that have improved efficiency, reduced costs, and really changed an industry. And so I think, right now, and there's a second trend here that we're not talking about, which is, the changing physician workforce and the changing healthcare workforce. Right now, you've got a very recalcitrant physician workforce. I'm going to throw my dad under a bus right now. He's not going to become a meaningful user of health IT. He told me as much. He's 3 years away from retirement, maybe 5 years away from retirement. You now have a group of physicians who are digital natives. I was at a meeting last week where someone said we need to have courses in medical schools to teach health information technology. And someone raised their hand and they said, people who are 22 years old who are tweeting at this meeting right now don't need courses on how to learn how to tweet. They just do it. They grow up with an iPhone in their hands. And I think those are the folks who are going to be the IT leaders at institutions. They're going to be the ones leading these institutions. And before you know it, it's going to be, these things will just change. And so we'll have conferences, we'll have meetings like this one, we'll talk about usability, but eventually there's just going to be a groundswell of kind of movement, a movement that's going to move healthcare into sort of a digital era. And it's not going to happen because the ONC says it's going to happen. It's not going to happen because John Halamka says it's going to happen. It's going to happen because it's going to happen. Just one quick anecdote to let you know how this just happens in the real world. We had this awful system for sign-outs at the Brigham, where literally people would be handing people paper in 18 different formats, to actually sign patients out at the end of the day. And then we heard that folks at the Mass General actually had a system. Somebody hacked into the system sort of on the back end and said, oh, maybe we can create a Brigham portal for this because we have a similar IT platform. And before you know it, without anyone instructing us, without the program director in internal medicine, without the hospitalist group saying we're going to use this system to actually sign patients out, the whole hospital was using this system to actually sign patients out. So I just think that this is good. Some of this stuff is just going to happen. Some of it requires, I think, regulation and, to ensure safety and some of the things that Jacob was referring to. But I'm not sure we're thinking about these issues in the right way all the time.
So, Jacob, to come back to you, is there a fundamental disconnect here between the notion of collecting more patient-generated data through all of these means, social, mobile, et cetera, and standards? Because for all of this to be really usable, we would want to structure this patient data, but maybe it can't or shouldn't be structured. I mean, how are we going to pull in the true benefit of that information in a way that's really usable, particularly research purposes and just even clinical purposes? How do we create some order among that mass of patient-generated data?
So this actually came up last week. We have a federal advisory committee, which John is the co-chair of, and now I have the responsibility of chairing as of last week. And the topic came up because lately there have been issues with patient advocates saying, hey, we need a standard for blankety blank. Let's just say it's blood pressure. And the health IT nerds say, well, wait, we've already got one. And the Fitbit creators and the innovators are creating data capture tools, and they may or may not be expressing that information in a way that's standard. What I've found through talking with these innovators is that when we say, hey, there's some train tracks over there, and guess what? It's whatever, I don't remember, 48 inches, 52? They love it. They're like, oh, well, we don't have to invent some new way to do this from scratch. This is really cool. So they're pulling the rope once they find out about these things. The challenge for them, ironically, is usability. The standards aren't as usable. They're hard to find. It costs money to use them. So these are things, as John was pointing at me, that the government could do better. We could point to the standards better. We could help to make them more consumable. We could evangelize some of the standards so that the folks in the innovation community understand what they are and then leverage them. So we wouldn't have an internet if it weren't for standards. And the innovators found those standards and have leveraged them well. And sometimes the standard doesn't do quite as much as an innovator would want to, and then oddly, that's what gets them involved in the standards development.
So will you evangelize about the existing standards?
Yes, we are, and we will more to help to evangelize, and also working with the standards development community to help them simplify. I think this is a challenge that we've had, especially in health IT, is that sometimes the standards get very complex, and the government has historically had a rather passive role. So we convene, we say, hey, standards folks, get together and talk, and what happens is the standards folks, not unlike academics, always want to think of the use case that the standard doesn't capture, because that makes them look smart to everybody else, right? Oh, well, what about this use case? You didn't think about that. And then the standard has to evolve toward perfection. And what we'd like to do is actually narrow the number of use cases to the, using the 80-20 rule and say, well, maybe that use case we could do later, but let's say the standard is simplified and we try and focus on just the 80% or the 20% of things that happen 80% of the time.
Which gets you to a low number like 816, for example,
Exactly.
as distinct from a much higher number. Let's talk about what would be the single most important next step to achieving the world that you all have been describing. And actually, I'm going to ask you now for Twitter length answers, about 140 characters or
Not to put you
less.
on the spot or anything.
Most important next step. Sachin, let's start with you. We'll give Jacob the last word.
I would say interoperability. So I think there's a coalescence of energy around that from the National Coordinator's Office, which I think is exactly the right thing. And so I think the extent to which we can sort of take that off the table. David Blumenthal used to say that health information exchange is a political problem, not a technical problem. And I think that's exactly the right framing. So I think the sort of bureaucrats and politicians need to solve it.
Okay, this is probably an edgy recommendation, but the current Meaningful Use program has a set of penalties associated with it for not achieving certain very prescriptive milestones. What about giving us incentives to accomplish radical care redesign and innovation as opposed to beating us when we don't have very prescriptive achievements? I would like to see a future in which we have a merit-based accomplishment program so that if I do Google Glass and it really works well, then fine, I have achieved something as opposed to being penalized for not recording this or that structured data element. So give me incentives.
And in what form would those incentives come?
Well, so today we have a huge variety of federal incentive programs, pay for performance this and PQRS and meaningful use. So what if we took dozens of these federal programs and rolled them into a single incentive structure that motivated us to have outcomes? You prescribe the outcomes, but then we decide the means, and if we achieve them, there is an incentive to be gained.
Which is more or less what the proposed SGR legislation would have done.
And that is what I was referring to.
Okay.
It was
Well,
proposed.
Yes, proposed, and there's always time. Jacob, last word to you.
This one's hard. I think I would focus on decision support as the goal, and I mean both decision supports that I referred to. So CDS in clinical decision support, but also consumer decision support. And as we shift toward empowering the consumer, as I think we all have agreed today, it means that we empower the consumer and we put the consumer in the center, truly in the center, so that, to your point, we're not scheduling things so that it's better for us, right? Because you don't see that in other industries. We're not thinking about the financial incentives so that it's better for us. And so I worry about who's got another motive to do something better, right? So we look at private payers. We even look at the federal government. We think, well, what's better for the nation? What's better for the people? And as we do that, we can see lots of hows, and we've talked about lots of the tactical hows today. But it all comes down to information and getting knowledge, right? So we've talked about data liquidity and moving data from place to place, but it's really about knowledge. And if we can get to knowledge liquidity so that providers and patients can share the knowledge, it's knowledge about this patient, we call that clinical data, but it's also knowledge about what best practice. We can weave those together in the ultimate mashup. That will achieve our shared goals.
And on that note, I think we could all agree that the knowledge liquidity factor this morning has been very high from these three very astute and distinguished presenters. So join me in thanking them for a terrific discussion.